Welcome to the Using Blood Wisely Clinician Education module. Using Blood Wisely is a national initiative of Choosing Wisely Canada in collaboration with Canadian Blood Services. The aim of Using Blood Wisely is to make a measurable impact to decrease inappropriate red blood cell transfusions in Canada using evidence-based guidelines and to recognize successful hospitals through Choosing Wisely Canada and Accreditation Canada. This education module is designed for prescribers of blood transfusion and healthcare professionals and will review the risks of red blood cell transfusions, review current red blood cell transfusion guidelines and evidence, highlight successful transfusion quality improvement projects, and share interventions and resources to help use blood wisely. To review these and other interventions in Using Blood Wisely, please visit our website at usingbloodwisely.ca. So why is it so important that we use red blood cells wisely? It's important to minimize harm to patients, including adverse reactions, especially transfusion-associated circulatory overload, or TACO, which is one of the leading causes of transfusion-associated deaths. Blood is a precious resource with ongoing concerns about the donor supply. Finally, blood is costly to collect and administer to our patients. So what are the risks of red blood cell transfusions? The most serious risks and common are TACO, as mentioned, which is likely underreported and occurs in about 1 to 6% of prospective studies. Transfusion-related acute lung injury, or TRALI, which occurs in 1 in 10,000, and acute hemolytic transfusion reactions, which most often occur due to human error in either sample or patient identification. Especially important in younger patients is the risk of alloimmunization, which can occur in up to 8% of the time and may threaten future pregnancies in young women or complicate future transfusions in those who need them. So, what are appropriate evidence-based red blood cell transfusion practices? The key Choosing Wisely messages are for restrictive transfusion in stable, non-bleeding inpatients. This means don't order or transfuse more than 1 unit of blood at a time. Don't order or transfuse red blood cells in asymptomatic, non-bleeding patients with hemoglobin greater than 70 grams per liter. This is probably true in the vast majority of patients. However, there may be exceptions, and it is important to adapt to the patient and clinical scenario. We will discuss this further in a few slides. Here is a graph of oxygen consumption versus hemoglobin and oxygen delivery, showing why a restrictive transfusion threshold appears to be as safe as a liberal transfusion threshold. In the 0 to 50 gram per liter range, transfusion is probably beneficial. However, even in this range, there are still cases where patients may tolerate these low hemoglobin levels due to severe chronic underlying nutritional deficiencies that should be addressed first. The need for transfusion becomes more debatable in the 50 to 70 gram per liter range, where the patient's health, nutritional deficiencies, and physiologic tolerance become important factors. Between 70 to 90 grams per liter, those with cardiac or vascular disease may derive some benefit, but otherwise transfusion is of limited value. At hemoglobins greater than 90 grams per liter, transfusion is unlikely to have a benefit. Across all hemoglobin levels, alternatives to transfusion, such as intravenous iron for iron deficiency, should be considered, and in some cases may be the primary therapy for anemia. Oral iron may be another alternative for outpatients with iron deficiency and those who are not at risk for a transfusion. If we look at the evidence, we now have multiple randomized controlled trials evaluating a restrictive transfusion strategy against a liberal transfusion strategy. It should be noted that in all of these trials, transfusions were given 1 unit at a time. There was no difference in 30-day mortality between restrictive or liberal trials. A restrictive strategy was also as good as a liberal transfusion strategy in elderly patients. The average age of patients in the FOCUS trial of hip fracture patients was 82 years old. In the recent TRIX-3 study of cardiac surgery, The restrictive strategy was also safe in patients older than 75 years old. In fact, they did better in the restrictive arm than the liberal arm. In acute upper GI bleeding, the restrictive strategy was in fact superior to liberal transfusion in terms of improved survival, less rebleeding, and fewer episodes of TACO. In all of these trials, the restrictive transfusion group used less blood products in terms of fewer number of red blood cell units and had fewer patients transfused overall. In orthopedic trauma in patients under the age of 55, they were randomized to either a 55 gram per liter restrictive threshold or a 70 gram per liter threshold as the liberal arm, provided they had adequate resuscitation following their initial trauma. The etiology of trauma was predominantly motor vehicle collisions and gunshot wounds. The group randomized to 55 grams per liter in the restrictive arm had lower infections at all points in their recovery. In fact, the only reason that the study was continued was that 70 grams per liter was considered the standard of care. So, in many, and perhaps most patients, restrictive is as good as liberal. However, some trials were published in the last couple of years that demonstrated some subgroup benefit to the liberal side, specifically in the setting of traumatic brain injury and myocardial infarction. In the setting of myocardial infarction, 4 primary trials, including Reality and MINT, individually found no significant differences in their primary outcomes. However, published meta-analyses and individual patient data meta-analyses suggest liberal transfusion strategies may produce benefit in the setting of myocardial infarction. Our expert opinion is to suggest considering a red blood cell transfusion in patients with acute coronary syndromes and anemia, where a transfusion threshold of less than 90 grams per liter may be considered appropriate. However, the choice to transfuse should still incorporate individual patient characteristics and system factors. Though a subgroup analysis of MINT suggests a benefit of liberal transfusion strategies in type 1 myocardial infarction, this alone should not guide transfusion and should be interpreted with caution. Type 2 MI has less robust evidence and strong clinical indications should be present before transfusing to a liberal strategy. Interestingly, the MINT authors in 2025 analyzed and published an algorithm using their raw data that they put through a machine learning model and published in the American Heart Journal, and found that using an individualized treatment strategy was better than either a blanket liberal or a blanket restrictive policy. There may be room for this to eventually be externally validated and a new standard for individualized patient transfusion decisions. In both arms, transfusion-associated circulatory overload was more common in the liberal transfusion target. Mitigation strategies, including furosemide prior to transfusion, should be utilized if risk factors are present. Minimizing iatrogenic anemia and treating iron deficiency also reduces blood transfusions and potentially improves patient outcomes. In the setting of traumatic brain injury, meta-analyses and guidelines have not yet been published at the time of this recording for patients with acute brain injury. From a practical perspective, there are also some key points to consider when giving 1 unit at a time. Blood should be transfused slowly over 2 to 4 hours. For patients who are older than 65, have impaired cardiac or renal function, transfusing over the longer length of 4 hours and considering furosemide pre-transfusion will help to reduce the risk of TACO. The patient should be assessed post-transfusion with a hemoglobin level before transfusing further. For non-bleeding patients, the hemoglobin can be assessed the following day. In general, expect that for each unit transfused in the average 70 kilogram adult, the hemoglobin will increase by about 10 grams per liter. Be aware of the clinical scenario that your patient is facing and incorporate both the hemoglobin and the signs and symptoms into your prescribing habits. Adapt to your patient. There is no one limit that defines a transfusion threshold. A young, fully resuscitated trauma patient awaiting definitive surgery may tolerate a hemoglobin of 55 grams per liter and have a lower infection rate, but a patient with active myocardial ischemia may benefit from a transfusion at 90 grams per liter. In terms of when to transfuse red blood cells, always assess your patient. But these are some guidelines that can be used. If the hemoglobin is less than 70 grams per liter, then transfusion is likely appropriate, remembering that younger patients or patients with chronic anemia may tolerate even lower hemoglobins. Some patients may require slightly higher hemoglobin thresholds in the 70 to 80 gram per liter range, such as those with underlying cardiac disease or those who are elderly. Finally, if patients are having clear signs and symptoms of impaired tissue oxygen delivery, then transfusing at a hemoglobin at or below 90 grams per liter may be beneficial. In risk stratification studies, 90 grams per liter appears equivalent to 100 grams per liter. So how are we doing in Canada? Is Canada using blood wisely? We know that there is a gap between evidence and practice. Published red blood cell transfusion audits suggest inappropriate transfusion practice can range from 3 to 57%. In an Ontario study, 20% of transfusions were inappropriate. We also know that by adopting single-unit transfusion protocols, red blood cell use can be reduced by 10 to 41%. While some variation may be due to differences in patients and populations, the above-mentioned data suggests it is worthwhile taking a deeper look at potential inappropriate transfusions. Now let's take a look at some successful interventions that reduced inappropriate red blood cell transfusions. The Ontario Transfusion Quality Improvement Plan was created to provide guidance on how to implement quality improvement activities to reduce unnecessary red blood cell transfusions at hospitals across Ontario. The quality improvement tools include education, changes in guidelines and transfusion order sets, prospective transfusion order screening by the blood bank technologists, as well as job aids and data capture tools. Implementing the interventions of guidelines, education, and prospective transfusion screening at Lake Ridge Health demonstrated a 31% sustained decrease in red blood cell use. The START study was a multi-center quality improvement research project taking place in 13 hospitals in Ontario, Saskatchewan, and Alberta. It investigated the use of laboratory screening of transfusion orders to improve transfusion practice. In total, 2,877 red blood cell transfusions were audited across the 13 sites. Findings show that appropriateness of red blood cell transfusions increased, orders for single units increased, and total number of red blood cells transfused decreased. In Niagara Health, the Using Blood Wisely program highlighted that their hemoglobin thresholds were already meeting benchmarks. But they identified and changed the habit of ordering 2 units of red blood cells, which decreased their 2-unit transfusion rate by 17%. In Regina, we noted a 19% reduction in monthly red blood cell use with education and order sets on intravenous iron, and then a further 18% reduction in red blood cell use with participation in the START study that was again sustained over time. So in summary, I hope you have learned about the benefits of reducing inappropriate red blood cell transfusions and are interested in participating in the Using Blood Wisely campaign at your hospital. Delivering the right blood product to the right patient at the right time is the goal of a well-functioning blood system. Prescribers, both physicians and nurse practitioners, drive the use of blood products, so it is important to stay abreast of the latest information and studies to assist patients in having the best possible outcomes. Both a lab and clinical assessment should be performed on the patient with every transfusion decision. Clinicians play a key role in championing appropriate blood use and helping other colleagues stay up to date. Nurses provide the constant bedside contact and communication with patients and families and are advocates for ensuring the best patient outcomes. In the context of transfusion medicine, nurses provide bedside support, ensuring the patient's lab and clinical condition align with the physician's prescription. When blood is ordered outside of guidelines, it presents an opportunity to improve patient outcomes by questioning the order. The medical laboratory technologist has an important role linking the blood supply to the ordering unit and can assist in pre-transfusion screening of orders and lab work, and ensuring best practice guidelines are available and referenced when ordering. They may assist in providing education and up-to-date resources in daily interactions with clinical staff. Regular audits and feedback also fall within the scope of practice of the MLT. Process changes should be celebrated as a team from the bedside to the laboratory. Participating hospitals may be eligible for the Using Blood Wisely hospital designation. In addition, implementation of Using Blood Wisely resources can be acknowledged as an organizational quality improvement initiative by Accreditation Canada's Cumentum program. If you are interested in learning more about how your hospital can reduce inappropriate blood transfusions, talk to your local transfusion medicine laboratory and visit us at usingbloodwisely.ca for more information, or email us at info@choosingwiselycanada.org. Thank you for partnering with us for transfusing wisely.